Hello everyone, welcome back. In today's lecture, we'll be moving on to renal system embryology. When we look at the overview of kidney development, the kidneys develop from intermediate mesoderm, and this happens through three sequential systems. So the first system there is Pronephros, and this is there at week 4, and this is usually non-functional and normally degenerates as opposed to Mesonephros, which is this second stage. And this is usually appear by week 4 and is present there until week 10. And this serves as the temporary kidney and it forms male genital ducts. And the last one is Metanephros. And this usually begins by week 5. And this is what is going to form the permanent kidney, which is the adult kidney. And then let's go through this stage one by one. So, like we mentioned earlier, so with pronephrons is the earliest kidney. And this normally appears by week 4 and is usually non-functional and rapidly what degenerates. And is the first kidney structure and is going to also what disappear. And then moving on to the next one, which is mesonephrons, which is our temporary kidney. This usually functions during the first trimester, and this acts as an interim kidney. And when we look at the mesonephrons, so the dots of that mesonephrons, which is what we call mesonephric dots. So that mesonephric dots in a male is going to form what? Is going to form male genital structure. And what are the male genital structure that come from this? So the epididymis, the ducts, difference, and the seminal vesicle. So this structure they develop from the mesonephric duct. And as you're going to see in a second, the distal part of that mesonephric duct, so that distal part of the mesonephric duct, that's going to become the ureteric bud. And the ureteric bud is going to be very important in forming our collecting what system. So the mesonephric duct in a female is going to degenerate. And then moving on to the third part of the kidney, which is going to be the permanent kidney, and that's the metanephrons. So as you know, as we mentioned earlier, in the metanephrons, that appear by week 5, and that becomes the permanent kidney. And then when we look at the nephrogenesis, the kidney development normally complete by week 36. So when we look at our permanent kidney, this depends on the interaction between two main structures, because two main structure comes together and they are the one that is going to become the permanent kidney or the permanent urinary system. So when we look at these two structures, so what are these two structures? So the first one there, which what we mentioned earlier, is the ureteric bud, right? And like I mentioned earlier, that ureteric bud is derived from the caudal end of the mesonephric ducts. And this ureteric bud is going to become canalized. We're going to create a hole in it. And that is going to become our conducting system. And then what are the systems that comes from this? What are the structure that come from this ureteric bud? So one, we're going to have our ureter coming from there, renal pelvics, the major calyces, the minor calyces, and the collecting duct. And this is very important for the exam, guys. We need to remember this. So ureters, renal pelvics, major calyces, minor calyces, and collecting duct. So these come from the ureteric bud. And as opposed to the metanephric mesenchyma. So the metanephric mesenchyma, this is going to become the glomerulus all the way to the distal convoluted tubule. So the glomerulus, the proximal convoluted tubule, the loop of Ehrlich, and the distal convoluted tubule. So these are going to develop from the metanephric mesenchyma. And the ureteric bud normally interacts. So that ureteric bud is going to interact, once the ureteric bud forms, is going to interact with metanephric mesenchyma, and that will lead to differentiation and formation of the glomerulus all the way through to the what? To the distal convoluted tubule. And that's why if there's a failure of this interaction, then this could lead to what? Congenital anomalies. And please, guys, don't forget the structure that come from our ureteric bud and the structures that come from the metanephric mesenchyme. And when we look at the ureteropelvic junction, which we're going to talk about in details later. So this is the point where our renal pelvis is going to meet with the ureter. And the reason why this is important because it's the last portion of the ureter to canalize. And if there's a failure of complete canalization, this could predispose to congenital uteropelvic junction obstruction in those patients, and that could lead to hydronephrosis. So let's talk about some pathology. First condition we're going to talk about there is renal agenesis. So renal agenesis occurs when the ureteric bud fails to develop or fails to induce the differentiation of the metanephric mesenchyme. And as we know, the normal kidney functions requires reciprocal induction because the ureteric bud needs to induce the metanephric mesenchyma in order for it to differentiate. And as we mentioned earlier, structure that come from the ureteric bud include what? Very good. So collecting ducts, our calyces, our pelvis, and the ureter. And as opposed to the metanephric mesenchyma, that include our glomerulus, right? Our proximal convoluted tubules, our loops, and our distal convoluted tubules. So all those structures, they all come from the metanephric mesenchyma. And if the ureteric bud does not develop, that means the metanephric mesenchyma is not going to be induced, and the nephrons will never be forms. And this is going to lead to complete kidney system, absence of the complete kidney. So complete absence of kidney and ureter. And then when you look at different types, it could be unilateral or it could be bilateral. So with unilateral renal agenesis, this is the most common form, and this is often asymptomatic because a patient could survive with just one kidney. But what's going to happen in that normal kidney is that normal kidney is going to hypertrophy. So there has to be a compensatory hypertrophy in order to, because of the increase in work overload. And then this patient usually have normal life expectancy. As opposed to bilateral renal agenesis, whereby there is bilateral absence of the kidney. And as we know that in the utero, right, the urine of the fetus is actually part of the amniotic fluid, because normally the fetus swallow the amniotic fluid into the lungs, and that allow their lungs to be able to develop, right, and that also maintain the high resistance in the lungs. And once they pee, their pee is part of the amniotic fluid. So that means if this fetus doesn't have any kidney, so that means they will not be able to pee. And if they can't pee, that means that will lead to decrease in amniotic fluid. And that's what we call oligohydramnios. So decreased amniotic fluid is what we call oligohydramnios. So as a result of that, that means there will be not enough amniotic fluid to be able to swallow into their lungs. So they could develop pulmonary hypoplasia. And because of the lack of amniotic fluid, then they will not have a cushion to be able to support them in the uterus. So they will have flattening facial features, limb deformity, and a low set ears. And this is what referred to as Porter sequence. And very important question. So they could ask, what's going to be the most common cause of death in these patients? And it's going to be the respiratory failure. And when you look at our prenatal findings, so like we mentioned earlier, so when you do ultrasound in this patient, they're going to have absence of the kidneys, empty renal fossas because of the absence of the kidney, and they ought to be absent or small bladder, and they're going to have very severe oligohydramnios, which means there's decrease in amniotic fluid. Moving on to the next pathology, which is multicystic dysplastic kidney. So this is a congenital non-functional kidney that composed of cysts of various size and with little or no normal renal parenchyma. And what's the cause of this condition? So this is caused by aberrant interaction between the ureteric bud and metanephric mesenchyma. So if there's an abnormal, because of the abnormal interaction between both of them, that leads to failure of induction of the metanephric mesenchyma to be able to form the kidney. So in this condition, the ureteric bud actually formed. So the ureteric bud is formed, but the problem is that it fails to properly induce the nephron differentiation. And then because of that, the kidney develops into a non-functional cystic mass. And then most often, this is usually unilateral. And like we mentioned earlier, if it's unilateral, most of the time, those patients have to be asymptomatic. But if it's bilateral, then this could create a problem for the patient. So the patient could develop things like oligohydramnios, which could also lead to what? Portal sequence. So when we look at the clinical findings that we see in multicystic dysplastic kidney. So prenatal, so often detected on prenatal ultrasound, whereby you're going to see multiple cyst appearance of the kidney, and it's usually unilateral, like we mentioned earlier. So because of that, cystic kidney, because it's not working, then the normal kidney is going to what? Hypertrophy, right? Because of the increasing workload. And then for postnatal, usually asymptomatic, they could have palpable abdominal mass in that unilateral side if it's unilateral, and then rarely they could develop hypertension. And on the imaging, usually shows multiple non-communicating cysts in one kidney, and then no normal renal parenchyma. And of course, like we mentioned, in the normal kidney, they're going to have what? Hypertrophy. And management. So most unilateral disease usually spontaneously involution over time. But if it's bilateral, then this could lead to renal failure. And you want to monitor for contralateral kidney for anomalies like vesicoureteral uretral reflux. And this is a gross pathology of a kidney that's showing multicystic disformed kidney and a dilated ureter. And moving on to the next pathology, which is autosomal recessive polycystic kidney disease. Autosomal recessive polycystic kidney disease. So this is a congenital cystic disease, which is characterized by dilated collecting tubules. And this is autosomal recessive inheritance, and they usually present in infancy or in childhood. And when we look at the genetic and pathophysiology, so the gene that's involved here is PKHD1, and we need to remember this gene for the exam. And this gene normally encodes fibrocystin, which is encoded by this gene. And defective in this fibrocystin leads to abnormal collecting dots, guys, collecting dots, and a bilateral tract development. And then when you look at this kidney, they're going to have small cysts in the collecting tubules. And then, like we mentioned earlier, the cysts are going to be in the collecting tubule. And most importantly, the way you're going to differentiate this from the multicystic kidney disease that we saw earlier is that in patients who have autosomal recessive polycystic kidney disease, they also have what? Hepatic fibrosis and a congenital hepatic disease. So that will help you to differentiate it from multicystic kidney disease. And when we look at clinical features, prenatal or neonatal, so they're going to have enlarged echogenic kidneys on prenatal ultrasound, and this is usually bilateral. Remember, as opposed to multicystic kidney disease, that could be unilateral, but most of the time this one is going to be bilateral, and then because of that, this could lead to oligohydramnios, and like we mentioned with oligohydramnios, this will also lead to what? Very good. So they could also develop portal sequence. So they could have pulmonary hypoplasia. And in infancy and childhood, they could develop hypertension. So if they survive through the prenatal phase, so they could develop, if they go into childhood, they could develop hypertension, renal insufficiency, and a growth retardation. Because as we know, with renal insufficiency, they could have problem with their vitamin D, they could develop rickets, and that could affect their growth. And then when you look at the imaging, so on ultrasound, we're going to see bilaterally enlarged echogenic kidneys with poor cortical medullary differentiation. And on CT, on MRI, we're going to see numerous cysts. But like we mentioned, those cysts are going to be confined to where? Collecting dots. Collecting dots, very important. And then when you look at the liver, you're going to see congenital hepatic fibrosis, which is going to be present in those patients. And then when you look at this image, here we can see a lot of cysts in both of the kidney. But in addition to that, you can also see something inside the liver. So you can see a lot of cysts, numerous cysts, also in the liver of that patient. And on this on the second image, we can see cysts which are oriented radially with a long axis at the right angle to the capsule, as you can see in those image. Moving on to the next pathology, which is uteropelvic junction obstruction. Uteropelvic junction obstruction. This is the blockage where the renal pelvis meets the ureter. And because of that blockage, that prevents normal urine drainage from the kidney. And like we mentioned earlier, remember we mentioned earlier that the uteropelvic junction is the last part to canalize. And because of this failure of canalization, this could lead to congenital what? Obstruction. And when you look at the pathophysiology, so obstruction causes impaired urine outflow, and because of the impaired urine outflow, then that leads to back pressure into the renal pelvis, and that leads to hydronephrosis. And the progressive renal damage could occur as a result of this. And this is the most common pathology cause of prenatal hydronephrosis. And when you look at the prenatal findings, so when you do your prenatal ultrasound, you're going to see dilated renal pelvis, and most of the time it's unilateral. And of course, if it's bilateral, you're going to see bilateral dilated renal pelvis. And in postnatal or in childhood, so they could have often asymptomatic initially, particularly if it's unilateral, but they could have flank or abdominal mass. They could have recurrent urinary tract infection. They could develop hematuria and a flanking after large fluid intake, because if they drink a lot of fluid, then that could cause more distension and that could cause flank pain for those patients. So how do we diagnose it? So prenatal ultrasound that will show hydronephrosis, and postnatal renal ultrasound. And a nuclear renal scan could also evaluate for the drainage and function of those collecting systems. And the management, if it's mild, you can just observe, and if it's severe, those patients might need what? Surgery. So this diagram is just showing hydronephrosis, and we can see the distension of the pelvis in those patients. Moving on to the next pathology, which is kidney ascent or renal migration. So as we know that kidney develops from the pelvis. So the kidney, our permanent kidney, are formed in the pelvis at week 5. And then once they are formed, then they ascend and move to the posterior parts of the abdomen. So they move to the retroperitoneal space. So by week 6 to 9, the kidney moves from the pelvis to the abdomen. And this is caused mainly by growth of the embryos as they grow cauda region, and they allow the kidney to migrate. And as kidney ascend, then new artery branch from higher levels of the abdominal aorta. So that's why we know that the blood supply to the kidney comes from the what? It comes from the abdominal aorta. And then those old vessels, they're going to what? Regress. And if there's a failure of regression, then sometimes those patients could develop what? Accessory renal artery. So let's talk about pathology that could be associated with failure of kidney ascent. So the first one there is pelvic kidney. So a pelvic kidney is a renal ectopia in which the kidney fails to ascend to the lumbar region. And that means that kidney is going to remain in the pelvis. And this could be unilateral. And then most of the time, patients are usually what? Asymptomatic, and it's usually incidental what? Findings. And then when you look at the embryology, so the kidneys normally develop from the metanephric mesenchyme, like we mentioned earlier, in the pelvis, and it should ascend retroperitoneal into the lumbar fossa by week 10, right? And if it fail to ascend, then the kidney is going to be arrested in the pelvic. And like we mentioned earlier, they could have aberrant vascular connections, right? And that could lead to maldevelopment of the ureteric bud and mesonephric and mesenchymal interaction. And then when you look at the blood supply of this pelvic kidney, so when you look at their blood supply and their location, so in terms of location, they are usually located anterior to the sacrum or near the common iliac vessel. And when you look at the vascular supply, often from common or internal iliac artery in those patients, and then can have multiple aberrant arterial supply. And then when you look at the ureter, usually normal insertion into the bladder, but maybe shorter in this patient. So when we look at the clinical findings, so usually asymptomatic, but those patients could get recurrent urinary tract infection because of stasis and malrotation of the kidney. They could develop hydronephrosis, kidney stone, pelvic pain, or mass effects. And then sometimes this could be mistakenly for ovarian or pelvic mass in a female. And the diagnosis, we can do ultrasound, CT, or MRI, and then we could also do intravenous pyelogram or renal scan. And as you can see in this image, we can see that this patient is having what pelvic kidney in this image. Moving on to the next problem with the kidney ascent, which is going to be horseshoe kidney. Horseshoe kidney. So what's horseshoe kidney? So this occurs when the inferior poles of the kidney fuse together during embryology. So like we mentioned earlier, the kidney developed from the pelvis, but in this patient, the inferior pole of the kidney fuse together, and as the kidney is migrating upward, it gets trapped under the inferior mesenteric artery. So this is the most common renal fusion anomalies, and it normally keeps kidney in the pelvis because they get trapped under the inferior mesenteric artery. So in horseshoe kidney, so the inferior poles fuse early, and the kidney attempt to ascend, and the ascent stop when caught under the inferior mesenteric artery. And we need to remember that for the exam. And when you look at the genetic association, so horseshoe kidney is strongly associated with Turner syndrome, and that's a high yield point, guys. And then when you look at the complications, so because of the aberrant location or anatomy of the kidney, it can lead to ureteral obstruction. Patient could develop hydronephrosis, vesicoureteral reflux, recurrent urinary tract infection. They could also have kidney stone. And then most patients are actually asymptomatic. And then when you look at diagnosis often incidental finding, prenatal ultrasound, and a CT or abdominal imaging. So when we look at this image, we can see the inferior pole of the kidney fused together. And again, we can see both kidney are fused together on that imaging. So now we've done with kidney development and associated pathology. Now we're going to shift the gear. We're going to now look at bladder development. So now let's focus on bladder development. So starting with the origin and development of the bladder. So the bladder developed from the cloaca, and this cloaca division normally divides into two. So the ureter septum is going to appear, and that will divide the cloaca into two. And then once you divide it into two, so the dorsal part is going to become the anorectal canal, whereby the ventral part is going to become the urogenital sinus, and that urogenital sinus will ultimately become the what? The urinary what? Bladder. So when we look at the urogenital sinus, so the upper part of that urogenital sinus, which is the largest part, is what is going to become the urinary what? Bladder. And as we know, the urinary bladder is going to continue with the allantoid and the yolk sac during what? During development. So that's why the bladder in the utero is connected to the what? Umbilicus, so that it's also so that it can be connected to the yolk sac. So the allantoid lumen should obliterate, right? And then once it obliterates, it normally form uricus in adults. And that uricus in adults is going to become median umbilical ligament. And these are high yield for the exam. And then when we look at the smooth muscle of the bladder itself, those ones are formed from this planic mesoderm. And the trigon also from mesoderma, and then from incomplete incorporation of metanephric what? Dot into it. Because remember, the metanephric dot forms the what? It forms the conductive system, and that conductive system will be able to drain into the what? Into the bladder. So that's bladder development. So what about urethral development? So when we look at male urethra, right? So male urethra are divided into four major parts. So we have the prostatic urethra, we have the membranous urethra, we have the pinna, which is also called spongy urethra, and then we have the distal spongy, which is also called the glans. So when we look at the prostatic urethra, so the origin, they come from the endoderma of the narrow portion of the urogenital sinus. So when you look at the prostatic urethra, membranous urethra, and penile spongy, the proximal part of the penile or spongy urethra. Those one come from the urogenital sinus, right? Whereby the distal spongy urethra that come from the ectoderma of the glans penis. So that's where that comes from. So like we mentioned, as opposed to in female, right? So in female, the entire urethra of the female, they all come from endoderma of the urogenital sinus. So now let's now focus on pathology that could develop as a result of failure of this or a defect in this in the formation of the bladder or the urethra. So the first one we have there is posterior urethral valve. So posterior urethral valve. So posterior urethral valve is a congenital obstruction of the male posterior urethra, and this is caused by abnormal valve-like membrane, and this is seen only in males. So this is a male problem, and it is the most common cause of bladder obstruction in a male neonate. So because, as you know, if you have the bladder, right, the outlet of the bladder is where we have the urethra, right, and our urethra is going to be drains into the what normally drains into the bladder. So that means if there is obstruction in this area, that means the urine will not be able to leave the bladder. So that will lead to bladder distension. Those patients want to have bilateral distension of what? Of the ureter, and that will extend into the pelvis, the calyces. So they're going to have bilateral hydronephrosis. And if this is severe enough, this could also lead to what? Oligohydramnios, which could lead to Porter sequence. So when we look at the embryology pathophysiology, so abnormal persistent of urogenital membrane in the posterior urethra, and that obstructs the urine flow, and that could lead to bilateral hydronephrosis, bladder distension, and potentially renal dysplasia. And this could lead to oligohydramnios if it's severe. And when you look at the clinical features, so in the in prenatal, so this is detected on prenatal ultrasound. So when you do your prenatal ultrasound, you can see this, whereby you see bilateral hydronephrosis, thick wall bladder, which is distended, and dilated posterior urethra, which is going to be our key clue in this patient. And they could have oligohydramnios, and that could lead to Porter sequence. And then postnatal or neonatal, so they're going to have poor urinary system, distended bladder. They could develop recurrent urinary tract infection because of vesicoureteral reflux, and they could have renal insufficiency. And a diagnosis, so like we mentioned earlier, so ultrasound is important. You could also do voiding cysto-ureterogram in this patient that will show dilated posterior urethra with valve obstruction. And what's the management? So early catheterization or surgical ablation of the valve to be able to allow the drainage of the bladder. And it's also important to monitor the renal function and then manage any complications. So the next one we're going to talk about is duplex collecting system. So duplex collecting system. So a duplex collecting system is a congenital duplication of the renal collecting system, which may include partial duplication or complete duplication in this patient. And when we look at the embryology, so this is caused by duplication of the ureteric bud. Because remember, we mentioned earlier that ureteric bud is what gives rise to the what to the collecting system. And what are the collecting system again? Right, the collecting duct, the calyces, very good, pelvics, right, and then those ones they come from the what? They come from the ureteric bud. And then each ureteric bud induces its own portion of metanephric mesenchyme, thereby forming a separate renal system. And when you look at the clinical features, so many patients are asymptomatic, and of course they could develop recurrent urinary tract infection. They are high risk for vesicoureteral reflux, and obstruction of the lower pole of the urethra will also occur, and they could develop hydronephrosis. And when we do our imaging, so ultrasound is going to show duplicated collecting ducts system. And when you do your voiding cysto-ureterogram, you can detect reflux of the urine in those patients. And then moving on to the next pathology, which is vesicoureteral reflux. And this one is really high yield for the exam, guys. Vesicoureteral reflux. So vesicle, so from the name, vesicle refer to the bladder, urethra. So that means there's a reflux of urine from the bladder into the what? Into the ureter. So this is a retrograde flow of urine from the bladder towards the ureter and the kidney. And because of that, this could lead to what? Recurrent urinary tract infection. And as you know, remember with urinary tract infection, it's usually an ascending infection. So it's usually an ascending infection. So it's an infection that comes from the bladder, and it could ascend into the ureter, and then from there it could ascend into the kidney, causing pyelonephritis. And with recurrent infection, with recurrent pyelonephritis, this patient could develop chronic pyelonephritis, and that could lead to renal scarring and fibrosis. I want to look at different types of this vesicoureteral reflux in terms of the pathophysiology. So it could be primary or it could be secondary. So primary vesicoureteral reflux is due to abnormal or insufficient insertion of ureter into the bladder. So when there's an abnormal or there's an insufficient insertion, that's what that will lead to primary vesicoureteral reflux. And it could also be congenital defect of one-way valve mechanism. As opposed to secondary, secondary is caused by increased bladder pressure. So there's something obstructing the bladder, or maybe there is lack of contraction of the bladder, like somebody who have neurogenic bladder. So because the bladder is not contracted, then that leads to increased bladder pressure. And because the bladder pressure is increased, then that forces the urine to retrograde from the bladder into the ureter. And it's important to remember these two for the exam because they are really high yield. So what are the clinical findings we're going to see in this patient? So most common in children, especially less than the age of 5 years, they could have recurrent UTI, like we mentioned earlier, like pyelonephritis, cystitis. And as a matter of fact, if you see a child that is having recurrent urinary tract infection, you should actually walk them off for vesicoureteral reflux. And then with recurrent infection, this could lead to renal scarring, hypertension, chronic kidney disease if untreated. And how do we diagnose this? So we can do voiding cysto-ureterogram, which is going to be our gold standard, whereby we are looking for the reflux of those the retrograde flow of contrast into the ureters and into the ureter and kidney. And you can also do ultrasound, whereby you can see agenesis or scanning of the kidney. And what's the management? So if it's mild, you can do prophylactic antibiotics and monitor. And if it's moderate to severe, like grade 4 to 5, those patients might need surgical correction. And then moving on to the next one, which is going to be Porter sequence, which we kind of like alluded to earlier. We spoke a little bit about Porter sequence. So Porter sequence is a constellation of physical anomalies that's caused by chronic oligohydramnios. Because like we mentioned earlier, we said that the amniotic fluid is really important. One, it acts like a cushion for the baby in the uterus. So if there's not enough amniotic fluid, then that could cause compression of those baby, and that could of those fetus, and that could lead to deformities. And we also mentioned that it's also very important for the lung pulmonary development, because the fetus normally swallow the amniotic fluid into their lung, and that allow the lung development. So if they have oligohydramnios, so that could lead to fetal compression, and that could lead to pulmonary hypoplasia. And that pulmonary hypoplasia is usually the most common cause of death in this patient. And when you look at the pathophysiology, so oligohydramnios leads to insufficient amniotic fluid, and a fetal compression leads to abnormal positioning, and pulmonary hypoplasia leads to insufficient lung growth, and this could lead to death in this patient. And when we look at the things that could cause this, so we divided in the causes into renal or fetal causes and maternal or placental causes. So when you look at things that could cause it from the standpoint of the fetus, so if the fetus have bilateral renal agenesis, like we mentioned earlier, so whereby they have bilateral absence of their kidney, that could lead to oligohydramnios, and that could lead to Porter sequence. If there's autosomal recessive polycystic kidney disease, well, like we mentioned, in those patients, they also have associated hepatic fibrosis and hepatic cyst. So that could be declared for you on the exam. So that could also lead to oligohydramnios, and that could lead to portal sequence. Obstructive uropathy, like a patient who has posterior urethral valve in a male, that could also lead to oligohydramnios, and that could lead to portal sequence. And when we look at the maternal or placental causes, so we have chronic placenta insufficiency, preterm or premature rupture of the membrane, and a maternal AC inhibitor. Because as you know, with AC inhibitor will lead to decrease in angiotensin 2. And as you know, angiotensin 2 is important to maintain the glomerular filtration rate, because it's going to cause efferent constriction, efferent arterial constriction, and thereby increasing the glomerular hydrostatic pressure, thereby increasing the glomerular filtration rate. So that means if somebody is taking ACE inhibitor, you're removing those angiotensin 2 effects from the efferent arteries, and then because of that, that will lead to decrease in glomerular filtration, and that will lead to decreased urine production, and that will lead to oligohydramnios. And that's why AC inhibitor is contraindicated in pregnancy, because it's teratogen. So when we look at the clinical features, so with portal sequence, so they're going to have facial anomalies, so they're going to have portal face, and when they could also have limb deformity, so they could have claw feet and a limb contraction in those patients. And in terms of pulmonary, they're going to have pulmonary hypoplasia, and like we mentioned, this is what is going to kill the patient. This is the most common cause of death. And a diagnosis, we can do prenatal ultrasound, in addition to recognizing the, in addition to identifying the oligohydramnios, could also help us to identify the etiology of the cause of the oligohydramnios. So moving on to urethral anomalies. Remember, we mentioned earlier that the when the bladder develops, we said that the bladder is connected to the yolk sac, right? By using the what? By the help of the urethus, right? And that urethus normally supposed to what? Obliterate and form median umbilical what? Ligament. And if there is a problem with obliteration of those urethus, it could cause different pathology. And let's look at different types of urethral anomalies. So the first one is going to be patent urethus. So that's when the urethus is still patent, it doesn't obliterate. And the next one is going to be urethral sinus, whereby there is a partial obliteration. And the next one is going to be urethral diverticulum. And the last one is going to be urethral what? Cyst. So let's go through them one by one. So the first one there is patent urethus. So this is when it failure to obliterate. And then what's going to happen as a result of that? So that means there ought to be a persistent connection between the bladder and the umbilicus. So that means the urine is going to be draining from the umbilicus. So urine drainage from the umbilicus because of the urethral fistula. And next one there is urethral cyst. So like I mentioned earlier, this is a partial obliteration, and they're going to have a central portion that passes. And most of the time, this patient is usually asymptomatic unless infected, and that could lead to midline infraumbilical mass. Next one there is urethral sinus. So this is urethral ends fails to close, and this could lead to fistulous tract at the umbilicus, and this could be draining fluid from that area. And the last one there is urethral diverticulum. So this is when the bladder end fails to close, and this may cause urinary stasis. This could increase the risk for infection, and a rarely patient could develop a malignancy from that area. So when we look at the complication of urethral anomalies in general, so infection, so cyst or the sinus could get infected, that could lead to abscess, cellulitis, malignancy is also another one. So chronic urethral remnants can really give rise to adenocarcinoma of the bladder. And this is usually midline at the bladder dome. And guys, I know it's been a long lecture. We've come to the end of today's lecture. And as usual, let's do some questions. So the first question there, a 25-year-old man undergoes abdominal imaging after trauma. The kidneys are fused at the lower poles and located lower than normal in the abdomen. The ascent appear arrested by a major abdominal artery. Which artery most likely prevented normal ascent? So as I mentioned earlier, this patient, looking at the image, this patient has Horseshoe kidney. and the vessel is going to be what? Inferior mesenteric artery. And moving on to the next question. A newborn develops severe respiratory distress shortly after birth. Pregnancy was complicated by oligohydramnios, and a physical exam shows flattening nose, low set ears, and a limb deformities. Ultrasound shows absence of both kidney. Which of the following best explains this condition? So this patient has renal agenesis, and like we mentioned earlier, renal agenesis is usually due to what? Failure of ureteric bud formation, and then because it failed to form, then it's unable to induce what? Metanephric mesenchyme in those patients. Next question. A medical student is reviewing kidney development. Which structure is derived from the ureteric bud? Remember, we said that from the ureteric bud, that's where our conducting system developed from. And that conducting system starts from where? It starts from the collecting duct. So the best answer there is going to be D. Moving on to the next question. A 40-year-old woman is found to have a kidney that's located in the pelvic during imaging. Which embryologic error occur in this patient? So this patient has a failure of what? Ascent. So the best answer there is going to be what? Is going to be B. Remember, like we mentioned earlier, this patient will have aberrant blood supply to the kidney because of the failure of the ascent. Next question. A fetus is found to have multiple non-communicating renal cysts on ultrasound. The ureter is absent. What is the most likely embryologic defect? So the most likely embryologic defect in this patient is that, remember, this patient has what? Multicystic kidney disease, right? And what's causing this is because even though you form the ureteric bud, but the ureteric bud does not interact with what? With the metanephric mesenchyme. So because of that, the kidney does not form properly. So the best answer there would be what? A. Abnormal interaction between ureteric bud and metanephric mesenchyme. Moving on to the next question. A neonate presents with enlarged kidneys and respiratory distress. Ultrasound showed bilaterally enlarged echogenic kidney, and the liver fibrosis is also present, which was the most likely diagnosis. So with bilateral cystic kidney, what appears to be Porter sequence and a liver fibrosis, this is likely what? Autosomal recessive polycystic kidney disease. Moving on to the next one. And don't forget, the cyst is most commonly located where? Very good, in the collecting tubule. So that's where they are most commonly located. Next question. A 5-year-old child is diagnosed with a kidney anomalies during evaluation for recurrent UTI. Imaging shows fusion of the lower poles of both kidney. The fused kidney is trapped under the inferior mesenteric artery. What is the diagnosis? So this patient has what? Horseshoe kidney. And then remember, it's important to know horseshoe kidney is associated with Turner syndrome. It's associated with Turner syndrome. Next question. A male infant presents with poor urinary stream and recurrent UTI. Ultrasound shows bilateral hydronephrosis and distended bladder. What is the likely cause? So in this patient has been having recurrent poor urinary stream. There's recurrent UTI, maybe likely due to vesicoureteral reflux. And now we've seen bilateral hydronephrosis and distended bladder in a male infant. So they're going to be what? Posterior urethral valve. Remember, if this is severe enough, this could lead to, in the utero, it could lead to oligohydramnios, and that could lead to what? Porter sequence. Next question. A male infant is born at 37 weeks and develops severe respiratory distress shortly after delivery. Physical examination shows flattened facial features and bilateral club foot. Prenatal ultrasound demonstrated oligohydramnios and there's markedly distended bladder. Postnatal imaging reveals bilateral hydronephrosis. Which of the following is the most likely underlying cause of this patient's condition? So again, here we can see male infants, right, develop severe respiratory distress likely due to and some feature suggestive of Porter sequence. And when we did our ultrasound, there's decrease in amniotic fluid, bladder is distended, and there's bilateral hydronephrosis. So this is also another case of what? Posterior urethral valve. Moving on to the next question. Um, a full-term newborn is delivered with severe respiratory distress, and physical examination show flattening facial features, low set ears, limb contraction. So that's also suggestive of what Porter sequence. But now let's ask ourselves, why is this patient having Porter sequence? So let's see. So prenatal ultrasound shows severe oligohydramnios. So there's bilateral renal agenesis, and despite resuscitative efforts, the infant dies shortly after birth. What is the most common cause of death in this condition? So the most common cause of death in this patient is going to be what? Very good. Pulmonary hypoplasia. Remember, we said that pulmonary hypoplasia is the most common cause of death in patients who have a Porter sequence. Next question. A 29-year-old woman with chronic hypertension is treated with an ACE inhibitor throughout her second and third trimester of pregnancy. At 34 weeks, ultrasound reveals severe oligohydramnios. The infant is delivered prematurely and develops respiratory failure and shortly after birth. Physical examination shows limb contraction, flattened facial feature. Which of the following best explain the mechanism underlying this condition, right? With ACE inhibitor, remember we said it earlier, ACE inhibitor is contraindicated in pregnancy because by taking ACE inhibitor, that will decrease your angiotensin 2. And if there's no angiotensin 2, you can't have the efferent constriction. You're going to have efferent dilation, and that will decrease the glomerular hydrostatic pressure, and that will lead to decrease in glomerular filtration rate, and that will lead to decrease in urinary production. So the best answer there will be what? Will be B. And then guys, if you have been enjoying this lecture so far, please don't forget to subscribe, like, and share this video. That will really encourage us to continue to make very high video like this. So let's continue. So the next question there, a newborn is found to have vesicoureteral reflux. Which embryologic abnormality most likely lead to this condition? Remember, we said that with vesicoureteral reflux, right, is when the urine is refluxing from the bladder into the what? Into the ureter. So that means there has to be a problem between the ureter and the bladder. So the best answer there was abnormal ureteric bud insertion into the bladder. And next question there, a 4-year-old girl presents with recurrent febrile urinary tract infection. Urinalysis shows leukocyte extract and nitrate. Avoiding cystourethrogram demonstrates retrograde flow of urine from the bladder into the ureter during urination. What is the most likely underlying defect? So this patient also have what? Like we mentioned earlier, if you see a recurrent urinary tract infection in a child, you should work them up for what? Very good. Vesicoureteral reflux. And the best answer there for this patient is likely going to be what? Something that has to do between the bladder and the ureter. So the best answer there will be shortening intravesical ureter, thereby allowing what? Vesicoureteral reflux. And then going to the last question, guys. A 10-year-old child with history of recurrent UTIs develops hypertension. Imaging reveals cortical thinning and renal scarring. Which condition most likely leads to this complication? So what will cause recurrent UTI in somebody that is young? Very good. Vesicoureteral reflux. And then because of the recurrent UTI, it appears that this patient has developed what? Scarring from those recurrent urinary tract infections. So the best answer there will be what? Will be C. Guys, thank you so much for listening. Please don't forget to like, subscribe, and share this video. And I will see you guys in the next lecture. Bye for now.